Hello, everyone. Welcome and thank you very much for joining us for this webinar today. Today's webinar is Enhancing Team Relationships, a prerequisite to the provision of person-centered care in residential care homes. It will be presented by Sienna Caspar from the University of Lethbridge. I'm Kate Duchek, a project officer with the Schlegel-UW Research Institute for Aging in Waterloo, Ontario, and I'm the moderator for this webinar. We're pleased to bring you this webinar through the Center for Learning, Research and Innovation in Long-Term Care program at the RAA. The RAA is a charitable nonprofit foundation that links research, training, and practice to enhance care and quality of life for older adults. The RAA supports practice-relevant research and mobilizes evidence so it can inform programs, be integrated into education and training, and influence practice and policy. As a program of the RAA, the Center for Learning, Research and Innovation in Long-Term Care, or the CLRI, aims to enhance the quality of care and life for people living and working in Ontario long-term care homes. We are supported to do this through funding from the Government of Ontario. And a bit of a brief background about me. I first walked into a long-term care home in 2001 when my grandmother living with Alzheimer's and Parkinson's diseases could no longer stay in her apartment. Soon after that, I started to study gerontology to ensure that long-term care communities are enjoyable places to live, work, and visit. So I'm very happy to support the RAA, the CLRI, and our many current and future partners to enhance our culture of aging. So our first question for you today is a poll. We just want to get a sense of who's out there in the audience. And the poll should be showing up on your screen now. So if you want to take a minute and just let us know which of these categories best fits you. And we'll give people a few more seconds to check their boxes. Yeah, so it looks like from our poll results that about 74% of people identify themselves or fit most into the other category. There's about 33% of people who say that they're RNs or RPNs, as well as some long-term care residents and healthcare aides or PSWs. So that's great. Thanks, everyone. And we're very excited to have Sienna Caspar present and lead this webinar for today. So I will now hand things over to her.
Hello, everyone. I'm not able to advance the screen because it had a message saying so long as the poll was open, I couldn't advance the screen. So we've run into our first technical difficulty.
Oh, maybe try to advance the slides now, Sienna. I closed the poll.
Okay. No. Oh, there we go. Hello. So first I'd like to say welcome to everyone who's decided to take their time to join us for this webinar. It certainly is an honor for me to be invited to present via this format. And I want to start this presentation with really giving you a little bit more information about who I am and what brings me to this place of wanting to really talk about enhancing team relationships and defend that as a prerequisite for the provision of person-centered care in residential care homes. So as a professional, I've worked as a recreation therapist, that's my clinical background, for close to 17 years in long-term care homes, both in Canada and in the United States. And in addition to being a recreation therapist, I was also a consultant in the United States with a team that was called Geriatric Healthcare Consultants. And on this team, I received additional training, and I was the dementia care specialist on this team. And in that capacity, myself and some of the other team members, we would go into long-term care facilities, and we would provide 4-day-long trainings on best practice in dementia care. And really, that's like, best practice in person-centered care in these facilities. And these facilities would actually ensure that because we mandated it really, that all staff were attending these 4-day trainings, and that included not just the care staff who are essential, but also maintenance and housekeeping and laundry and dietary, because they recognized that it takes an entire team to provide the best practices in care. And we would ask at the end of these 4-day trainings, which is, I mean, that's a huge amount of resource and investment of resources. And we would get feedback on these trainings from the staff and ask them to evaluate the 4-day training. And they would all say, it was amazing. It was so awesome. We learned so much. We're so excited. And we were thrilled. And because I was a consultant, I was able to go back into these facilities, though, and really look at, okay, well, what changed as a result of this education and training. And across the board and consistently, what I found was that nothing had changed as a result of this. And that was what led me to my next role, which is a researcher, because I decided that it wasn't the individuals that were resisting this change in care practice from perhaps a more medical model to a person-centered care, that it must be something beyond that, and something that I didn't understand enough about. And I decided it was a systems issue, because I saw this repeated so many times, and that led me to go back and do my graduate studies, both my master's and my PhD, and then my postdoc. And so for over a decade now, I have researched to try to answer this question of why. Why is it so hard to implement person-centered care despite significant motivation to do so and significant effort to alter care practices? In addition to being a researcher and looking at this and researching long-term care homes and facilities, I've also had the experience of being a family caregiver. And I think it's important to share that, because it's all three of these that that create the lens with which I conduct research, and also how I'm motivated as well to do this work. So as a family caregiver, I actually, the loved one that I cared for who had dementia was actually my husband. At the age of 49, he was diagnosed with stage 4 cancer, and he ended up with a thankfully rare disorder called leptomeningeal disease. And so the cancer spread to his brain via his cerebral spinal fluid. And so I had this profound opportunity to actually really put everything that I thought I knew and understood about person-centered care to the most profound and intimate test. And I resided with him on palliative care for 3 months, which were the last 3 months of his life. And during that time, he no longer knew who I was, but he knew that life was better when I was in the room. And he also could no longer really advocate for himself and his needs and what would enable him to really receive person-centered care. And so I became that advocate, and I had knowledge that the care staff needed to know, needed to access, needed to enact to enable him to have not just a good quality death, but also good quality life leading up to that. And what I found is that there was inconsistency in how the care staff accessed this information from me, and whether or not they enacted it, and whether or not they acted upon that information. And in some cases, that resulted in some adverse outcomes for him. Even though I had ensured that this individualized care information about him was in the care plan, in some cases was even posted up on his room, on the walls in his room, because I knew the system, I knew how, where we were supposed to communicate this care information. And so it's these three experiences that really, and life roles, I guess you could say, that really have driven my burning question. And I've already alluded to that, but this question that keeps me moving forward and motivated to try to answer is, why is person-centered care so hard to consistently implement? And my focus is within long-term care homes or facilities. And as I've also already stated, I believed, based on my personal and my professional experience, that the answer is likely going to be found through studying the organizational systems as opposed to individuals. So that burning question is what made me go back to school after there was a gap of almost 17 years between my undergraduate and my graduate studies. And my research question for my master's was really trying to explore what the relationship is between long-term care staff's access to empowerment structures and their perceived ability to provide person-centered or individualized care. And to get at that, I recruited participants from 41 different long-term care facilities across 3 health authorities. And I asked them questions about their access to what's called structural empowerment, and then also about their perceived ability to provide individualized care. And this is a structural equation model. You will not be tested on this. It's actually a visual representation of the results of that study, but I'm going to just describe what this shows. And what this shows is that for care aides, and also I will say for LPNs or licensed practical nurses and RNs, there was a significant association between their access to empowerment and their ability to provide person-centered care. And that's not at all a surprise, in fact. What was a surprise is that this, and I'm hoping you guys can see, this variable here called informal power for care aides was the most significant variable of the empowerment structures that influence their ability to provide individualized care. It was so significant that it actually mapped directly onto individualized care. Why this matters is that it was even more influential to them than resources. And resources is about staffing levels and about access to even supplies. And that was a surprise to me, more influential than support. Although these absolutely are really, really, really important, there is something about this variable called informal power. And the theoretical foundation for that study was based on Cantor's theory of structural empowerment. And according to Cantor, informal power is derived from the quality of alliances and relationships with people in the organization. So what that finding suggested is that, especially for care aides, the quality of their workplace relationship has a direct and meaningful influence on their ability to provide person-centered care. So that was fascinating to me, and but it was just a statistic, and statistics certainly can't answer all of your questions and don't paint like a rich picture of understanding how or why. And so because of that, I decided I couldn't stop at my master's and I needed to go on and continue to explore this, and I went on to do my PhD at UBC in the Interdisciplinary Studies program. And for my PhD, I chose to do a qualitative study, and I used the method called institutional ethnography. And based on institutional ethnography, it asserts that you can understand organizational systems by studying the institutional texts within them. And so in a long-term care home, an institutional text is any document upon which we gather, store, and share information. So in this context, these would be policies and procedures and assessments and care plans, to name a few. And in an institutional ethnography, you also need to choose a standpoint. And your standpoint is basically selecting a group of individuals from within that institution that you are going to view the system from their standpoint. And so for me, I chose the care aides because of any group of individuals in a long-term care home. In my opinion, they have the greatest influence on whether or not person-centered care is offered and implemented on a day-to-day basis. So my questions for that study, here's a few of them. One was, how do institutional texts impact the everyday care practices of care aides? And what texts, and really that means information, do care staff have access to, and how do they access it? And then also, what does this tell us about how the care work is socially organized in long-term care facilities? And I'm going to be very upfront and share with you that my husband was diagnosed with his cancer right in my second year of my PhD. studies. And so absolutely that personal experience influenced these questions, because I wanted to understand, how do care staff access this personalized, individualized information, and where do they store it and how do they share it as a result of that personal experience. So what I did is I went into 3 different long-term care homes. They were of similar size and admission policy. And the one thing that was different between them is that they represented the 3 different ownership statuses. So one was private for-profit, one was private not-for-profit, and one was public not-for-profit. And I recruited incredibly brave and just amazing, actually, care aides who allowed me to shadow them for the full extent of their shifts in days, evenings, and nights. And after I shadowed them, I interviewed them to get a more deeper understanding of what their experiences were and perceptions were of that shift, and also to confirm or challenge some of the things that I had observed. And it's important for me to point out that although I was shadowing the care aides, they were not what was under investigation. What was under investigation was the organizational system within which the care aides work, and really exploring how that system supports or impedes their ability to provide person-centered care. So in addition to observing and interviewing the care aides, I also did what I call 360-degree interviews. So I interviewed the LPN, who was the team leader on that shift, and then I would also interview the RN, who was the kind of charge nurse, if you will, for lack of a better term, who oversaw, the whole facility often during that shift. And I interviewed the administrator and the administrative assistant, and I interviewed dietary, and I interviewed recreation therapy. And in one facility, if you really wanted to understand what was going on, you needed to interview maintenance. So I interviewed the maintenance guy. And of course, I also interviewed residents and family members. And so all in all, I conducted 76 different interviews with individuals from these 3 different long-term care facilities. And in addition to that, I did textual analysis. So any document that I observed that the staff were engaging with during the course of their shift, and also importantly, some of the documents that I knew about that they weren't engaging with, I would analyze them. And my focus in all of this was on how resident care information is accessed and shared within the care teams. And that's because of my experience of saying, if you're going to provide person-centered care, you have to have access to that personalized, individualized care information about the people for whom you are providing care to. So what I found in a nutshell is that in long-term care, if you're looking at access to resident care information, there seems to be a fence with 2 sides. And on one side of the fence, the work is very textually mediated. And on this side of the fence, the adage, if it's not documented, it didn't happen, truly reigns supreme. And on the other side of the fence, the work is very, what I refer to as socially mediated. And in fact, very little of the knowledge, the information, the intimacies of the work that occurs here actually gets documented. And it was on that side of the fence, where it's socially mediated, that I found the residents, the family members, and the care aides to be situated. And on the other side of the fence is where I found the entire rest of the care team, all of the regulated care staff members. And as a recreation therapist who worked in long-term care for 17 years, I have to say I was firmly entrenched on the other side of the fence, where the work was textually mediated. And I also have to acknowledge that I had no idea during that time that this fence existed. Having discovered this fence and this simile of a fence, if you will, I decided that I needed to look for gates. It's like, okay, if there's this fence, where are the gates? Because the individuals on both sides of these fences need to have access to the information that the individuals have on the other side. And so where are the gates? And if there is a gate, which way is it open? Is it only open one way? So information is only flowing perhaps from the top down. Or is it only open the other way, where information is only flowing from the bottom up, but not from the top down? Or perhaps, are there gates in this fence that actually enable information to freely flow between both on both sides of the fence. And based on this simile, I actually created a visual representation of information exchange via textual documents within all 3 of the long-term care facilities. And this next slide, and hopefully you can enlarge this, is one of the 3 facilities that I went into. And I know that that's incredibly hard to read. So I'm just going to summarize some of the key findings. And that's that in all 3 facilities, none of the care aides, who are actually the ones who are doing the vast majority of care, had access, practical or feasible access, to any of the assessment information. Also, in all 3 of the facilities, none of the care aides were consistently included in the annual care conference, nor did they ever see the care conference plan or review. They didn't see the results of the care conference consistently. And in 2 of the facilities, in 2 of the facilities, the care staff, the care aides, also did not have access to the resident's social history. And also in 2 of the facilities, none of the care aides had access to the actual care plan, practical access. They knew that they were supposed to go read it, and they knew whenever surveyors or licensing inspectors, or there's different titles for these roles in each of the different provinces, but whenever they were under review, they knew to tell the reviewer that they always went and read the care plan. However, I never actually saw any true time for them to go do that when I was shadowing them. It was not built into their day-to-day care practices. And the only ones who were able to access them were the ones who worked in the night shift, when hopefully most of the residents were sleeping. The other thing that was significant is that in all 3 facilities, none of the family members or the residents had ever seen their care plan, and also all the family members that I interviewed did not know that this existed, that there was this detailed care plan. And so that's an issue. That's a concern. In the one facility where they could access and where they ensured that there was practical and feasible access to the care plan, to the care aides, this was in a facility that had permanent resident assignment. And so because of that, they photocopied the care plan and they put it in a binder for all the residents who were in that particular unit. And that binder was on the unit so the care aides could access it. And I was really excited about this. And so I interviewed care aides and tried to find one who actually went and read them. And I was only able to find one who consistently read it. And I asked her, so that's awesome. And what do you get out of that? And she said, this is, I quote, "I find it really entertaining to read them. It's like reading a fiction novel. It's 12 pages of care that's been developed by someone who's never actually given them a bath." And so she didn't read it for its usefulness or practicality or to inform her care. She read it out of almost interest, you could say. And also in all 3 sites, the care aides had no idea how they could influence, or that there even were influencing, the content of these care plans, which were really supposed to be describing and driving the care that was being provided to the residents. So what I learned from that, I learned that although they provided 80% of direct care, the healthcare aides lacked practical access to the institutional texts that contain important information relevant to the residents' care needs and preferences. And this is a quote from a manager elaborating on this. And she said, so some RNs will allow them, some facilities will allow them, and she's talking about the healthcare aides, to read histories. Many facilities say it's not their right to read a chart, so therefore they're terrified to go and to get them so that they know more about the residents that they're getting into the personal space of. And even if they actually can go read them, they don't have time. So what I summarized from that then is that, in fact, these institutional texts that are being developed, and there's a lot of resources that go into this, there's a lot of energy that goes into these texts, these care plans, the assessments, And the focus of them, the purpose of them, is supposed to organize and prescribe residents' care. However, they were exerting little, if any, influence on the care aides' daily care practices, because, of course, and this is a systems issue. It's not an individual issue. The system does not encourage and enable them to not just have access to them, but to also influence them, which is what's necessary to make them actually practical. And this was a quote from a care aide: "You just get used to going in blind." And I found that a really poignant example of that when I was shadowing on one of my shadowing times, and I was there at day shift, and we were sitting in morning report, and the team leader said, "We have a new admission, and a head-to-toe assessment has been completed." And that was the only information that the care aide had before she was supposed to then go into this individual's room and provide morning care. So what I learned from this also is that there were only 2 institutional texts that the care aides had practical access to that were regularly and systematically updated. And this is so across all 3 facilities, there was only 2. And these were the bowel lists and the bath lists. And from an institutional ethnography perspective, this finding would make one conclude that regardless of the philosophy of person-centered care that may be espoused in these organizations, in fact, the real priority is keeping the bowels clean and the body, the bowels moving and the body's clean. And that's a problem. And the other thing that this communicates to the care aides regularly is that their role on the care team is in fact primarily about doing just that, about keeping the bowels moving and the body's clean. And that's something that also is contrary to what so many of the people I interviewed said, which was this acknowledgement that the care aides were the hands and the heart of the organization, that they were central on the care team. And yet this being communicated, what this communicates to them from at a systems level is very contrary to that. And this is summarized by one care aide who said, "We don't have the responsibility of the RNs and the LPNs and the pills and all that stuff, but I think our job is equally important. And lots of people don't know that because they just think we're professional bum wipers. Really, that's not near what it is." And that's also significant if we're looking at what impedes the provision of person-centered care. I think this messaging on an organizational level, on a systems level, to the care aides on a regular basis also impedes the provision of person-centered care. So what I learned then is that due to the lack of access, practical, feasible access of going and actually accessing these texts and also influencing them to be a part of the development of them, care aides instead conducted informal assessments and created their own individualized care plans on a daily basis. And this individualized information that they have about the residents for whom they are providing care is stored in their minds and in their hearts. Very rarely does this information actually get captured within the written institutional text. And I have to say that despite this system, I did see amazingly, profoundly beautiful examples of person-centered care. I also observed care that, quite frankly, was sometimes very hard to watch. But by and large, the care was outstanding, and really, there were so many demonstrations of their personalized knowledge of the residents that they learned by doing. So it was tacit. So for an example of that is a resident who, after being admitted to the long-term care facility, had had a stroke, and subsequent to the stroke, she would drool down one side when she ate, and she was embarrassed of this. And the care aides had figured out that if you faced her with over a tray table and you faced her towards the window in the dining room, she would still eat. She would still eat independently. But if you faced her towards her table mates and kept her at the table, she would refuse to eat because she was She was too embarrassed, and she was too uncomfortable with her now change in functioning level. And the CARES knew this, and so they did this, but it wasn't in any care plan. What's also important is that this information that they would gain like that, which is really important and individualized and person-centered, that information was stored in their minds and their hearts. And if, therefore, it was shared orally, meaning that they would tell each other. And this process of sharing this individualized information was absolutely dependent on the quality of their workplace relationships with one another, and also, interestingly, with management. So what I want to do is remind you of that structural equation model and that statistic that linked the quality of the workplace relationships directly into person-centered care. And here's part of the answer I found as to why that is. And it's because it's their access to this individualized care information, other than what they learn, sometimes the hard way, but often what they learn on their own in the room, their access to it from each other is dependent upon whether or not they get along with each other. And this quote from a care aide summarizes this quite well. If two girls don't like each other, one great tip that one had that could save us all time and injury doesn't get shared. So whether or not they share that information is greatly influenced by the quality of their relationships with one another. And not only does that impact obviously the staff, because, and she says it in this quote, injury, because they can be at risk if they don't get this information. It also obviously very much impacts the residents who are receiving care. It impacts their continuity of care. It impacts their quality of care. And I would even say it impacts the ability of the relational care on some level too, because whether or not that personalized information is being shared from shift to shift or team to team is largely dependent on on the quality of their relationships. So in addition to observing and finding that the care aides lacked practical access to institutional texts within these organizations, I also found that they now, and I believe that this is one of the unintended consequences of the implementation of the computerized medical record or the electronic medical record, which is pulling so much of the team. So often the team leaders are being pulled off the floor and have to spend much more time behind a desk and in front of a computer screen. That there's also a lack of a clearly defined open two-way gate between the care aides and the LPNs and the RNs. The care aides had to, and they are the ones who are the first to see when there's a change of condition in a resident care status, the first to see when there's a red area on a scan, they're the first to see when there's changes in how they're eating, in their continence, they're the first to see when there's a problem with often with medication. And so they have this information that is absolutely essential that they get up to the other side of the fence, to the LPNs and RNs. But what's happened is that because we no longer often have an end of shift report, that kind of went the way of the dodo bird when we started moving around and changing shifts to try to cover things more effectively. But team leaders are not leaving at the same time that the rest of the team is, or the teams, there's some people who are working part-time, and there's there's these unintended consequences that are negatively impacting bringing the team together and actually talking with one another. And one of the significant things is this impacting the care aides being able to talk with the LPNs and the RNs on a regular basis. So what they're having to do is do it on the fly. They're having to watch and see when is a good time for me to go and share this information with the LPN or the RN. And oftentimes, in my observations, what I saw is that the best time for them to share this information that they had with an LPN was when the LPN or the RPN was on the floor passing meds. And that's the worst time for the RPN to receive this information, because their attention needs to be focused very clearly on the med pass. And it's also, so what happens is the RPN, or what happened in my observations, the RPN or the LPN had to make a decision. Did they take their attention off the med pass and really thoroughly give it to the carried and the information the carried is giving them, or did they keep it on the med pass? And what I observed is that the majority of time they kept it on the med pass. And again, that's understandable. This is, again, a systems issue. But what occurred as a result of that is that information that the carried gave them kind of fell through the cracks, wasn't followed up with consistently. And these included things like a gangrenous toe, pain that wasn't being managed, an infected eye, those types of things. And the worst unintended consequence of that is that the carried said, if this happens too many times, I simply throw up my arms and say, what's the point of reporting anything? Nothing's happening in response anyway. And that's a very disconcerting outcome. And so there must be a better way for the carrieds to be able to share information with the team leaders, and the team leaders are able to really respond and let them know exactly what's happening in response to the information that they've communicated. Because we cannot have the carrieds give up and no longer communicate the information that they have about resident care needs or changes to resident care needs. So this model, or I don't know if, yeah, I guess it's a model. This pyramid kind of summarizes all of my findings into one succinct place on what actually enables person-centered care, what supports person-centered care in long-term care facilities based on my research, or this research that I'm presenting on today. And what I found is that and I will actually say that although I saw a lot of challenges, obviously, because I've shared them, I also saw a lot of exemplary samples of person-centered care. So I was really looking at what enables that. And what I found that did is the presence of empowered managers and team leaders, that this is foundational to the provision of person-centered care. And in large part, it's because it's foundational to the culture within which the care is provided. So when there were empowered managers and team leaders, they engaged in 3 specific behaviors on a regular basis. And one was respect. And respect is summarized in these 2 quotes from care staff saying that they trust that their opinion counts, and also that they matter, and the work that they do matters. Like, I matter and the work I do matters. So the team leaders are consistently communicating to them that they matter, the work that they do matters, and that their opinions, their concerns count. The other is recognition, that they get caught doing a great job and that they actually feel appreciated. Again, when team leaders are pulled off the floor and further away from the floor, there's less and less opportunity for the care staff to get caught doing a great job. And we're actually, quite frankly, just not that great at really expressing appreciation, and we need to work on that. So when that's present, it's hugely influential for the care staff. And then finally, responsiveness. And this is encapsulated with this quote of, my concerns are responded to. And that's that feedback loop, that follow-up when they have a concern. When there is the presence of empowered managers and team leaders, that really helps to cultivate trust within the organization, within that unit, that house, that floor, that facility. And the trust is that's kind of the 2 quotes that I have is that I trust that I'm cared about as a person. If we want care staff to provide person-centered care, we need to also ensure that they feel cared about as a person within that organization. And I also trust what management says and does. When there is this trust, that seemed to be essential to the development of these supportive team members and the presence of these supportive team members. And the term or the theme that was really strong when there were supportive team members is this idea of reciprocity. And that's that we don't just take care of the residents, we also take care of each other. Or another one was, we are a family here. When there's this reciprocity, that enables resilience for the care staff as they face really significant workplace adversities on a regular basis. And the 3 that were the most present and prevalent when I was doing my observations were dealing with scarce resources, safety issues, and grief. So scarce resources is an interesting one. 40% of my observation periods, the staff were working short. And when I contacted a senior administrator, he said, yep, that's about average. And the staff said unequivocally, I'd rather work short with a great team than work on a fully staffed team where there's dysfunction and discord, when I don't think anyone has my back. And they didn't want me to say that out loud, because of course working short is not good. It's not what they want, but that's how important having a great team is, and the quality of the workplace relationships is. And also supplies or linens, very interesting. It's a fabulous litmus test to know if you have a reciprocity in your teammates, to see how they manage being short on linens. In the team where there was lots of reciprocity, they would come together and say, okay, we're coming to the weekend, or we're in the weekend, and we know we have not enough of everything, so who needs what? And they would divvy it out, because there was no mine and yours. In the other teams, man, the hoarding is just so creative, in some ways so disconcerting, but also unfortunately and sadly understandable. And then this idea of safety. Show me a care plan that has a resident who's engaging in responsive behaviors, and I'll show you a care plan that says that the staff are supposed to go in with a buddy, that there's supposed to be two people. And what I observed and what was communicated to me is whether or not there is a second person to go into the room with them was dependent upon whether or not they were friends. They were friendly with each other. They cared about each other. Again, this is the quality of workplace relationships that's influencing their safety in their day-to-day work life. And then finally, grief. And this is an important story to tell. It was in my last facility that I was in, and I'm embarrassed to say how long it took me to actually see this, to really see this. And I was in a report, and it was day shift, and the team leader said, we have a new admission. And I heard it. I heard all the care aides take in this deep breath and hold it. And they were holding it until they heard what room number, because that's how they were going to find out who died. And the team leader stated the room number. One care aide's head dropped. Another care aide was watching her because she knew what that meant to that care aide. And then they made eye contact, and the care aide mouthed the words, Annabelle died? And the other care aide nodded. And this care aide had less than 8 minutes to process this information, that this person who she had cared for, not just provided care to, but cared for, was gone. And yet the organizational system completely disregards that there's actually a relationship here, that there's some grief, that there's perhaps a broken heart. And that's a problem. And when I asked the care aides, the care staff, if they felt support through this grieving process when residents died. First of all, I'll say they all experienced grief. Every one of them cried when they talked about their experience of resident death. And they said that if they received any support, it was from other care aides who understood. And again, then that support is based on and determined by the quality of the workplace relationships. So when there is this workplace, these positive workplace relationships, this reciprocity, it enables resilience, which enables a quality of work life, which absolutely supports quality of care and person-centered care. So here's a question for you. Sorry, I'm going over. I start telling stories and I get too kind of verbose. But the question is, does anyone have any good examples of ways in which we can support care staff's grief when residents die? And I don't know if you want to jump in here or if I should just continue on. What we thought we would do is let people write in their answers, and then we can share them as soon as I'm done concluding the presentation. So I'll go ahead and move on. Does that sound good?
Yeah, yep. And then I was just going to remind people that to type in their responses to this question in the questions box, which should be along the right-hand side of their screen. And then we'll get back to people in a few minutes, so that way they have some time to think about it, type in something, and then we'll give them some more information in the meantime.
Perfect. So basically, to summarize what all I found is that really, again, it comes back to leadership. because leadership is so influential on the culture within which the care is provided. And when we're looking at leadership, it's really about connection. And I love this quote from Brené Brown's The Gifts of Imperfection, who states, "I define connection as the energy that exists between people when they feel seen, heard, and valued, when they can give and receive without judgment, and when they derive sustenance and strength from that relationship." And I think when leaders enable care staff and the care teams to feel seen, heard, and valued, that's what enables care staff, encourages and inspires them and motivates them to help residents feel seen, heard, and valued as well. And based on these findings, I then, some of my more recent research is in the development of what's called the responsive leadership intervention. And in this I created a formal system to really help support this oral information exchange, because I decided, based on my experiences and findings, that care teams need to come together and they need to talk. That we can't just document things, because documentation does not equate communication, and especially not for the care aides who really want to talk with one another, who want to problem solve together, who want to learn from one another, and the ticky boxes and the documentation is not the best format for them. And so this responsive leadership intervention is composed of 3 components, and one was a one-day workshop where we trained the team leaders on really how to facilitate a care team huddle. And by encouraging and enabling and empowering the whole care team to come together and to be part of developing the care plans, and then enacting the care plans. And then we implemented daily care team huddles into the care practice. And then we also developed a team leader support system. The results of that were quite wonderful, actually, and especially, obviously, not obviously, but especially for the care aides. This bringing the team together and giving the care aides an opportunity to share their knowledge and also share their concerns and have this follow-up feedback resulted in some wonderful outcomes. And here's a few quotes to kind of summarize them. So one is, the care aide said, "It's better communication. No one really shared or talked about what we were charting, but now we're talking to one another and sharing important information we didn't always hear before." Another says, "We rarely receive feedback from the RNs and LPNs about charting, but now because we're doing huddles, most shifts we hear back about our questions or concerns." And then finally, definitely improving problem solving. We had one resident that was expressing very difficult behaviors, and after a huddle discussion, we came up with a better way to approach the resident, which worked much better. So we're coming back to that question now, and then also this is when everyone has an opportunity to ask any other questions of me that I might be able to answer.
All right, yeah, and thanks everyone for taking some time to enter in your responses. We got a lot of them. People were saying that in response to this question, that there's regular memorial ceremonies in the home, that there's a debriefing after the death of someone, and again, that they have a memorial service. They talk about it during team huddles. One home has a condolence book that people sign or a comment on that's then given to the family afterwards. Some homes, they have a chaplain or a religious leader come in to talk with people, you know, whether on a one-to-one basis or talking with them in the moment. They offer peer-to-peer support. One person said that their home has a guard of honor where staff line up and wait for the deceased resident to be brought out of their room, and that they have a quilt made for this purpose that covers the person. And it's done that way until they go out the front door as a real celebration of life, which is what a couple other people commented about. So it seems there's a lot of really respectful and creative ways that people are trying to support the direct care staff after their beloved residents pass away.
That's awesome, and so important. When people ask me, what can we do, when they hear my presentation and they recognize that there needs to be some improvement in this area, and they ask me what they can do, all of these are wonderful examples. And the most important thing, if there's anyone out there listening going, okay, those all sound great, which one am I going to implement? My answer to that question is always find out from your care staff what they need, what they say they want, what will matter to them. And one size will definitely not fit all. And so it needs to be more perhaps than one thing. And it needs, and you're going to need to be open and flexible and be creative. The most important thing is to acknowledge that we are a death-averse culture, that we don't deal with it well. We don't like to talk about it. And so I think it's fabulous, all of those examples that just came up of long-term care homes that are not trying to, for lack of a better word, pretend like it's not happening. Because I've certainly worked in a facility that was like that. My manager wanted me to decrease our memorial services down to once a year. And I just knew in my heart that that would not meet the needs of residents or family members, and especially not care staff. So here's another poll question. Sorry, Holly, am I supposed to turn this over to you now? Does anyone else have a positive experience or an example of implementing care team huddles in residential settings?
All right, we have the poll up on the screen now for people to select yes or no as their answer. Give people a few more seconds to check their response. And it looks like it keeps varying between 50-50-ish, yes and no.
Yeah.
All right. And then we had oh, sorry, Sienna, go ahead.
Yeah, so for those of you who are in the yes category, yay. And for those of you who are in the no, who are interested in perhaps implementing something like this, I encourage you, there's a couple of publications that I put up there, maybe review them to see how we did it, but also find out who's doing them and learn from each other. I have to say, I just think it's essential. And so long as we are ensuring that we really are following up and listening to and empowering care aides, even though all of them will initially say they don't have time for this, they will find it. I had care aides actually be the ones to ensure that it was consistently happening because they saw how valuable it was, not just with their ability to communicate and share information with their team leaders, which is essential, but also to come together and share information with each other. Because when there is a structured time to be able to do that, then it decreases the reliance on them being friends to access that information. Then casuals get that information too and can ask information as well. And that's something I didn't mention in my presentation, is that everyone benefits, I think, from care team huddles, but for casuals, they're essential for access to information. So Kate, should I just turn over the screen to you and let you do the, sorry for asking these questions in front of everyone, but.
Oh, no, that's totally fine. That's the way it goes with webinars, live in the moment.
Okay.
Or if you want to switch it over to the next slide. So in follow-up to the poll question, we're wondering, what people think who responded yes, that what was essential in making the huddles a success. And so again, everybody with a response just entered into the questions box on the right-hand side of your screen. All right, and people are giving us some responses that they keep it brief, that there's engagement and support from management, positive participation and interdisciplinary input, having that open dialogue and trying to keep things on track, and while trying to actively listen and offer a respectful and positive response. And then one person gave a detailed answer that for huddles, there's a time frame of 10 minutes with a clear
Oh, are you still there?
Purpose for either high-risk care issues, palliative care situations that are more difficult to use. So yeah, lots of various ways that the audience gave as to how to make huddles successful meeting time.
So there's a couple of things that got pointed out that I think I just want to elaborate on, because I think they are so essential. And one is management support. If you have team leaders leading huddles and they don't feel backed by management in order to be able to actually respond to the concerns that are brought forward, huddles have the potential of dying on the vine, as I say. And where they have had the most profound success is in the facilities where if the team leader cannot address the concern that's brought forward or cannot implement the recommendation that's brought forward during the huddle, then the manager makes the commitment, or a person who can address that makes the commitment to come and attend the next huddle, and so that everyone, so that there's empowerment there to be able to make change. If that's not in place, unfortunately, sometimes the huddles can just simply be another replica of a feeling of disempowerment, and that it doesn't matter what we say, nothing's going to change anyway. So that management support is absolutely essential, and also keeping it sweet and short. It can't, so 10 to 15 minutes is what we would encourage people to do. And what's required there is both that real active listening and really hearing the people. So asking open-ended questions, doing reflection, those types of skills, communication skills. You can get a lot accomplished in a short period of time if you're using some of those strong communication and leadership skills as well. Great answers, though. Wisdom out there.
Yeah, definitely. And then last but not least for our question, if people have any further questions or comments, to put those in the questions box now. We are going to end the webinar recording in a few minutes, so that way we're keeping to the 1 hour time frame. But Sienna has kindly offered to stay online for a while afterwards, so that way if you want to have a further discussion with her, she's more than happy to stick around to answer your questions. All right, and one question we had that came up earlier is somebody wants to know, how do we put this research into action when managers...
Oh, for some reason I can't hear you.
Oh, sorry about that. I know my computer can be a little bit flaky with the mic, and I have to get that figured out. But one person had asked of how to put this research into practice when managers don't support the team's ideas.
Well, that putting this research into practice requires responsive leadership. The other thing, though, that can occur, and I will say I've just completed a study in a long-term care facility where I actually changed care practices in meal times without a manager in that facility, because the position was actually open for, I think, 7 months, was by really galvanizing a team and finding leadership anywhere within the hierarchy. I will acknowledge, though, that they had the support of me as a researcher and external, so I was kind of like an interim leader, if you will. Yeah. I think it's what you do on your day-to-day work in cultivating positive relationships within your team, and also cultivating positive relationships with the residents that you're caring for, is how to enact this, and acknowledging that that's much harder to do if the culture is not established and set that way by leadership.
All right, thanks, Sienna. And somebody else was asking if you have any recommendation for homes to make care plans more accessible to PSWs or healthcare needs, both physically and time-wise. And a follow-up question to that was that if you have any ideas for casual or part-time staff or team members to give them the information they need.
Yeah. Well, so I think it's essential that you one of the best things that I've seen is reviewing when care conferences are coming up, reviewing that care plan in the huddle, so that everyone actually has access to and becomes a part of it. If the care staff become a part of the development of the care plan, they're much more invested in it, and that we need to actually review it with them and go over it. And the only other thing is making sure they have practical access to it, which often means having to copy it and making and having it be in a place where they a part of their workspace, and that would be individualized to each care facility, if you will. But keeping it in, especially on the computers, not giving them access, and unless it's unless there's like kiosks and there's multiple spots. Like I haven't seen that yet, and maybe there are places where that exists. But having them, on charts in behind the nurse's station, they're just never going to go access them. So being creative, figuring out how to get them to access them. But even if you give them physical access, like in the one facility, if they're not involved in the development of it and the revision of it, it still won't influence their care.
All right, thanks. And there were a couple people who asked us a similar question, so they're wondering if there's any formal processes or guidelines other than the huddles, and somebody similarly was wondering where she would be able to find guidelines in order to perform a proper huddle.
So the one, I think that she can write to me directly, or if I could send you like the steps to a huddle that I implemented in the responsive leadership intervention. Kate, are you willing to like share that out? Is that easy to share out? Or
Yep. Because we were planning on doing, after the webinars, that we were going to follow up with people with a survey link to get their feedback on it, and we can send people any more information then or at a later time.
Yeah, sure. So I can provide you how the steps that I lay out when I help facilities implement this, and it's literally do this, then this, and this, and this. And then also I would encourage you to reach out to other facilities that might be nearby that have implemented huddles, and go watch them and talk with them. But I'm happy to share as many resources as I have and that I've developed.
All right, and then last but not least, for the question that we'll do while the webinar is still recording, is someone would like to know, how do we teach the staff to communicate better between each other?
Yeah, I think that's really about bringing them together in person. I can't tell you how many communication books I've seen actually negatively impact teams and relationships. There's something about when we write something down, we can depersonalize and actually get mean because we're not actually in the room together, and really working hard at finding ways to enhance the relationship in general will help staff communicate with one another. And maybe that is actually doing something that doesn't typically always fit with us, but is to have everyone start their day by saying tell me one thing about you that none of us know, or something, so that they become people to each other, and you help to cultivate those relationships. And then the other thing is to take some, have everyone learn and use open-ended questions, and enhance their listening skills. And those are some simple but really powerful communication skills as well. Great questions.
Indeed. Yeah, so this brings us to the end of our formal time for the webinar, and thanks very much for participating in it, everybody. So as I was saying, that we want to know your thoughts about it and any suggestions you have for future webinars. So we'll be sending you a short online survey via email to you soon. And thanks very much again to Sienna for sharing with us this very insightful and inspiring information. And special thanks to Holly Hebner from the RA for her wonderful webinar support. So So like I said, we're going to be ending the webinar recording now, but Sienna is going to stay online for a while to answer any more questions you have. So thanks again, everybody, and enjoy the rest of your day.